Okay friends, in the second lecture we will be talking about neurological localization. We will be taking a hypothetical case and we will try to fix the lesion in our neuraxis. By neuraxis, what does it mean? Neuraxis means you have cortex, then you have subcortical white matter, then you have corona radiata, then you have internal capsule, then you have midbrain, pons, medulla, and your spinal cord. In a spinal cord, then you have anterior horn cell, then you have nerve root, then you have plexus, right? Then peripheral nerve, neuromuscular junction, and muscle. This is your neuraxis. Now just imagine, weakness is very common. Weakness is a very common symptom, and in any part of your neuraxis, if you have a problem, you can come to have a weakness. So you should know how to fix a lesion somewhere in this neuraxis. So we will be using a simplified diagram where we will be taking this brain, and we have made a neuraxis like midbrain, pons, medulla, and downwards spinal cord. This is a neuraxis. So suppose this is a right hemisphere, this is your left side of brain, right? This is your central sulcus. You have precentral gyrus and a postcentral gyrus. This is a motor area, face and arm. Face is laterally, arm is slightly medial, and leg fibers are medial. Face and arm, this is your sensory area, right? Then you have your sylvian fissure, from where you have your blood vessels of middle cerebral artery which comes and supplies. So my corticospinal tract, it starts from my motor area, goes down from the same side, and at the junction of my medulla and spinal cord, it crosses over. This is my corticospinal tract, right? So suppose this is your right side, this is your left side. Suppose you have a patient who is diabetic or hypertensive, right? Suppose 60-year-old male who has diabetes and hypertension. This male reports that he encountered sudden onset weakness in his right arm, right leg, and right side of face. Right arm, right leg, and right side of face. So where do we put our lesion? So obviously in neurology, whenever you have a sudden catastrophe, it is mostly vascular in origin. It is not tumor, right? So it is vascular in origin. So we presume that patient must have had stroke. So where the stroke is, can it be on the cortex? Can it be subcortical? Can it be in midbrain? Can it be in pons? Can it be in medulla? Can it be in the spinal cord? It can be anywhere. Till anterior horn cell, it can be anywhere. So a high cervical cord lesion before the anterior horn cell can produce hemiplegia, but you won't have a facial weakness. And then in spinal cord, just involvement of lateral corticospinal tract is highly uncommon. It's very difficult to have an anterior spinal artery occlusion or some other problem that specifically cuts off your corticospinal tract. There will be some sensory problems also. So spinal cord lesion is extremely unlikely. Similarly, when we are talking of brainstem is a small structure densely packed with cranial nerve nuclei, and you have sensory fibers also. So this patient is telling us that there is no sensory involvement, only pure motor problem of right arm, right leg, and right side of face. So brain automatically says that it may be a cortical problem, right? Conventionally we think like that. However, it is not. Reason, the blood supply to motor strip and the sensory strip is similar by MCA. So if you have a cortical problem, then there would be sensory abnormalities also. So this is not a cortical stroke. This is a subcortical lesion. This is a subcortical lesion, somewhere maybe in the internal capsule. If I draw my internal capsule, there is genu. In genu you have corticobulbar tract. In the posterior limb, the anterior aspect is corticospinal tract, and the posterior aspect you have sensory fibers or spinothalamic tract. These sensory fibers are communicating with VPL of thalamus, and from VPL of thalamus the thalamocortical radiations are going to your sensory strip. This is your thalamocortical radiation. Got it? So what is happening is the blood supply, if we think of subcortical white matter, we again by convention will think that, oh, the blood supply should be similar of posterior limb. It is not so. The blood supply of this area is by ventriculostriate branch. The penetrating branch of MCA before its division. Ventriculostriate branches, they are supplying this part of your internal capsule, and the posterior part is supplied by a different artery, which is not deep penetrating branch. So most of the strokes which occur in diabetes and hypertension are small vessel strokes, right? And that is the reason you have pure motor involvement. And this is the most common presentation in stroke. You have pure motor involvement in internal capsule stroke, right? Suppose this patient comes to you with saying that I have lost sensations also. So then probably it's a cortical stroke. Okay. Whenever you have a MCA stroke, remember arm weakness is more than leg weakness. Whenever you have MCA territory stroke, the arm weakness is more than leg, because leg fibers are more medially, right? Suppose this patient gives you a history that his left eye has ptosis, mydriasis, and it is down and out. Suppose this patient also gives you a history that with right-sided hemiplegia, right facial nerve, right facial weakness, he has left eye which is ptosis, which is down and out, and the pupil is large. That means there is a third nerve involvement. Where is your third nerve? Third nerve is in midbrain. So it's a classical Weber syndrome, wherein you have involvement in your midbrain, third nerve, and the corticospinal tract gets involved. So you have contralateral hemiplegia, whereas the nuclei of the cranial nerve are from the same side. They are involved in the same side. Suppose this patient tells you that he has a problem in facial nerve innervated muscles, or he cannot look towards left side. Whenever he looks towards left side, he has diplopia. That means he has involvement of 6th nerve as well as 7th nerve. So the problem is in pons, because the nuclei of 6th nerve and 7th nerve are in pons. So you can just by history of hemiplegia, which is contralateral, and you have 6th nerve and 7th nerve on the side of stroke, on the left side. So you can tell that probably the problem is in pons, left pons. Suppose patient tells you that when he takes out his tongue from his mouth, the tongue deviates towards left side. So that means you have involvement of 12th nerve, which is there in medulla. See, 12th nerve, right nerve will push tongue towards left nerve will push tongue towards right. So if I lose my left nuclei, my tongue will deviate towards left side. Similarly, as my 6th nerve, if I lose my 6th nerve nucleus on the left side, my eye cannot see towards left side. So whenever I will try to move my eye towards left side, right eye will move, but left eye won't. So you will have diplopia. But on other side, it won't. Other side, it will move in a conjugate way, right? So this is the way of differentiation of how do you do it. Suppose this patient tells you that he is unable to speak. He is able to understand, but he is unable to speak. So probably he has Broca's aphasia. So where is Broca's area? It is in the inferior frontal gyrus. Here, Broca's area. Right? So you have a superior division of MCA which supplies Broca's area. So if you have hemiplegia with Broca's aphasia, you can very well say the problem is in inferior frontal gyrus superior division of my MCA. Suppose patient says that the eyes are deviated away from hemiplegic side. Eyes are deviated away from hemiplegic side. What does it mean? It means that there is an involvement of frontal eye fields. Frontal eye fields are in the middle frontal gyrus. So what happens is the left frontal eye fields are pushing eyes towards right side. Right frontal eye fields are pushing eyes towards left side. So if my left frontal eye field is gone, the right frontal eye field will push my eyes towards left side. So patient who has involvement of MCA can come to you with frontal eye field involvement with loss of contralateral power, right? So this is a way of localization in any stroke, right? Whenever you have involvement of cortex or cortical stroke, you generally have sensory findings. In a spinal problem, you don't have a facial weakness. In a spinal cord, you cannot have isolated, power loss. You tend to have sensory problems also. Whenever you have a brainstem lesion, you tend to have cranial nerve nucleus involvement. But always remember, the lesion will be on the same side. The findings will be on the same side of the lesion. They don't cross. Cranial nerves, apart from cranial nerve 4, doesn't cross, right? So this is the end of neurological localization. In next lecture, we'll try to understand further about stroke.